for now, two topics that I'll be discussing. One is on tension pneumothorax and the other one is on quality indicators. So with regard to tension pneumothorax, so coming to the introduction, it's basically collapse of the lung when air accumulates between the parietal and vesical pleura within the chest. So air is outside the lung but inside the thoracic cavity. So this places pressure on the lung, leading to collapse and shift of the surrounding structures. So pneumothorax can be classified either as a simple pneumothorax or a tension pneumothorax. So the difference between them is the shift of mediastinal structures. In simple, there is no shift of mediastinal structures, whereas in tension, there is shift of mediastinal structures. So coming to the etiology, it can be traumatic, atraumatic, and miscellaneous causes are there. So under traumatic, it can be penetrating or blunt trauma and iatrogenic. So penetrating and blunt trauma can lead to rib fractures, and that can lead to tear in the pleura, which can lead to pneumothorax. Whereas iatrogenic causes can be because of CVC insertion, routinely with the use of the internal jugular vein and subclavian, especially when a beginner tries to attempt central venous catheterization. It is pretty common. Then lung biopsy, percutaneous tracheostomy, pacemaker insertion, bronchoscopy, during CPR, and intercostal nerve blocks, and also another one that is missed is intrapleural nerve blocks. So all these can lead to pneumothorax. So under atraumatic, you can classify it as primary or secondary. So under primary, it is situation where the cause is unknown. So the risk factors for atraumatic primary pneumothorax would be cigarette smoking, cannabis, cocaine, and genetic predisposition in patients with alpha-1 antitrypsin deficiency or Marfan syndrome. The risk of developing atraumatic pneumothorax is pretty high. And due to increased Valsalva maneuver, as in diving or military flying. And secondary atraumatic pneumothorax is seen in patients with underlying lung disease like COPD, lung malignancies, necrotizing lung infections like pneumocystis, TB, or bacterial infections like Streptococcus, Staphylococcus, Klebsiella, and Pseudomonas. Under miscellaneous causes, it can be because of anorexia, catamenial, or exercise induced. So all the causes mentioned above can lead to a tension pneumothorax. So that is the important thing you need to keep in mind. So coming to the pathogenesis, under normal circumstances, pleural cavity pressure or intrapleural pressure is negative as compared to the lung pressure and atmospheric pressure. So there is a tendency of the lung to recoil inward and the chest wall to recoil outward because of this negative pleural pressures. So the pressure gradient that develops in the pleural space prevents the lung from collapsing. So during a pneumothorax, a communication develops between the pleural space and the lung. So it causes air movement from the lung into the pleural space. So this nullifies the pressure gradient that is usually present, leading to a progressive rise in intrapleural pressure. So air accumulates in the pleural cavity through the disrupted pleura, but is unable to exit like a one-way valve. So this leads to an increase in intrathoracic pressure in the affected site. So the increase in intrathoracic pressure in the affected site can cause compression of that lung, decreasing its volume. So leading to collapse, and the affected lung is unable to function at its normal capacity. So that leads to a decrease in gas exchange, leading to hypoxia. So that causes stimulation of your hypoxic pulmonary vasoconstriction, leading to an increase in pulmonary vascular resistance, leading to worsening hypoxia and decrease in your cardiac output. On the other side, compression of the mediastinum leads to pushing it to the contralateral side. So it compresses the heart and the great vessels, reducing the preload and cardiac filling pressures. So that also contributes to a decrease in cardiac output. Ultimately, this decrease in cardiac output and worsening in hypoxia can lead to cardiac arrest if not treated in a timely manner. So clinical evaluation. So in history, usually they present with sudden onset breathlessness, which can range from mild to severe. Unilateral pleuritic chest pain could be there. And it is important to look for risk factors and genetic predisposition. So physical exam, in mild cases, the exam findings are insignificant, whereas in severe ones, there can be enlarged hemithorax on the affected side, diminished breath sounds, absent tactile or vocal fremitus, and hyperresonance on percussion. Hemodynamic compromise, if it is present in the background of a pneumothorax, it is supposed to be a very ominous sign. So, with regard to the diagnosis, when an ABG would reveal hypoxemia with respiratory alkalosis due to well-functioning contralateral lung, whereas if respiratory acidosis sets in, it's an ominous sign indicating patient fatigue. So, metabolic acidosis, if it is there, it is hyperlactatemia related and it indicates a diminished cardiac output. So ECG is usually non-specific. The most common finding is sinus tachycardia. If the patient has a previous chronic parenchymal lung disease, then usually right bundle branch block with RV strain may be seen. So chest X-ray is not usually done in unstable cases due to logistic issues. The effective position, the air moves to the least dependent portion of the lung, and thus the radiographic appearance of pneumothorax depends on the patient's position. So in a supine position, that is in mechanically ventilated patients, the pleural gas accumulates anteriorly in a subpulmonic function, leading to the deep sulcus sign, where the gas outlines the costophrenic sulcus. So other findings that can be there are subcutaneous emphysema, tracheal deviation to the opposite side in cases of tension, and in patients with pneumomediastin, there can be a continuous diaphragm sign where both the leaflets of the diaphragm can be seen as one. So here you can see there is a pneumothorax, and here you can see the deep sulcus sign. So this is supposed to be a continuous diaphragm sign, which is indicative of a pneumomediastinum. Sorry, this was the one. The previous one indicates subcutaneous emphysema over here. So this is the continuous diaphragm sign where you can see that both the diaphragm is seen as like a single structure. So for assessment of size, as per the British Thoracic Society guidelines, the distance from the chest wall to the visceral pleural line at the level of the hilum is usually taken into consideration. So if it is less than 2 centimeters, then it is considered as small, whereas if it is more than 2 centimeters, it is large. So it correlates roughly with the pneumothorax occupying 50% of the thoracic cavity. So there is another formula, that is the ABC formula. So you take 3 areas of the pleura, the distance between the parietal and the visceral pleura. So the vertical diameter, the vertical distance, then the distance at the upper end and the distance at the lower end. So you would get A, B, and C, and then that summation needs to be done and divided by 3. So that would give you a percentage of the pneumothorax. So this is also another method of assessing the size and quantification. So pleural ultrasonography, the usual findings that need to be there are absent lung slide, absent B lines, absent lung pulse, and a presence of a lung point. So if all are present, it indicates pneumothorax and with a very good sensitivity and specificity. So the sensitivity is 94% and specificity is 100%. So CT scan is not done in cases of tension pneumothorax for obvious reasons. The patients are hemodynamically stable, transfer to the CT room. The time during which it is done itself can lead to a cardiac arrest. So this is just few images thought I should show you. This is a lung point. So it is a transition zone on the ultrasound where the normal lung sliding meets the absent sliding, and its present is nearly 100% specific for a pneumothorax. So presence of lung point is supposed to be pathognomic for a pneumothorax. So other two things I told were lung sliding. So this is a one image with the normal lung sliding, but in pneumothorax there would be absent of lung slide. And here you would see presence of B lines. So B lines usually indicate congestion, but in a patient with a pneumothorax, because of air occurring between the pleura, occurring between the parietal and the visceral pleura, the ultrasound waves are not able to penetrate beyond that air. So that images that are produced subsequently are unable to reflect the congestion that is present below it. So usually B lines are not seen. So usually when a patient who has respiratory distress and you suspect pneumothorax, if you identify presence of B lines, then it nullifies the presence of a pneumothorax. So lung pulse. So it refers to the sonographic finding of apparent oscillations of the pleural line occurring secondary to transmitted vibrations from the cardiac contractile activity. So the treatment, the first part of it is airway breathing and circulation needs to be stabilized. If hemodynamically unstable, first you need to do needle compression without delay in the second intercostal space at the mid-clavicular line. So following this, the chest drain is placed attached to the water seal. The technique can be either a Seldinger technique or a dissection-based technique. If there is no hemodynamic instability, then there is no requirement for a needle decompression. So this going ahead with the second intercostal space at the mid-clavicular line was as per the general guidelines, but now in the latest ATLS, the concepts related to this have changed. So the basic rationale for doing a needle decompression is to convert a tension pneumothorax into a simple pneumothorax. So doing that is not the definitive therapy. You will need to proceed with a thoracostomy drain. So recent evidences support placing the large over the needle catheter at the fifth intercostal space slightly anterior to the mid-axillary line. So that is where now they recommend to do the needle decompression. So there may be certain scenarios like in obese patients, due to the variable thickness of the chest wall or kinking of the catheter and other technical or anatomical complications, needle decompression may not be successful. So in this case, finger thoracostomy is an alternative approach. So here you can see needle tension pneumothorax can be managed initially by applying a finger decompression technique. So for selection of tubes, for majority of cases, like stable cases due to spontaneous or iatrogenic etiology, usually a 18 to 14 French is sufficient, but not if the patient has features of tension pneumothorax. For patients on mechanical ventilation or with the presence of a tension pneumothorax, you will need to go with larger thoracostomy tubes, usually 24 to 28 French is preferred, mainly due to the risk of bronchopleural fistula. So the rationale for tube selection is based on the Hagen-Poiseuille equation. So basically flow is proportional to pressure on the fourth power of radius and inversely proportional to the viscosity and the length of the tubing. So this flow and the length of the tubing plays a big role. So routine use of negative pressure suctioning is not recommended and there is no evidence to suggest its benefit. So coming to the placement, this was asked in the DRNB paper 1 2 years back. So it is important to know about the anatomy. So any pneumothorax is best treated with the chest tube placed in the fifth intercostal space just anterior to the mid-axillary line. So the triangle of safety is the one you need to know. So the base is at the level of the fifth intercostal space. The apex is at the base of the axilla. The anterior part of this triangle is the lateral edge of the pectoralis major, and the posterior part border is by the lateral edge of the latissimus dorsi. So this needs to be remembered. So differential diagnosis in relation to chest pain and dyspnea. One, there can be pulmonary embolism, acute coronary syndrome, pneumonia, acute pericarditis, rib fractures, esophageal spasm, and acute costochondritis. So this is about the first talk.